Hi, Mike Gibson, Jim Januzzi here with our year in review for heart failure. Jim, a big year in heart failure. Why don't we start off with amyloid? Hot area this year.
Yeah, really hot. I mean, the heart failure space is just on fire right now, Mike, and part of it, I think, reflects the fact that heart failure has become such a dominant problem in modern cardiology. It's really the final common pathway for so many diseases. And you mentioned amyloid. It might surprise the viewers, maybe if they jumped in a time machine from a year or two ago, because there wasn't much to talk about. But now, my gosh, I mean, there's so many different therapeutic options that are coming in this calendar year. We heard about more data regarding stabilizing the transthyretin molecule. So we had already learned about tafamidis. We now, in the attribute trial, heard about acoramidis. This was a drug that stabilizes transthyretin and was associated with anywhere from a 20 to 40% reduction in mortality, heart failure hospitalization. It lowered NT-proBNP. It improved 6-minute walk distance. So we have another tool in the toolbox soon to arrive for stabilizing transthyretin.
And
But
maybe
the
more potent in stabilization than the Pfizer molecule, correct?
correct, more potent, and I think importantly, giving us other options, which will no doubt provide further opportunity for treating even more patients. Um, More exciting, though, besides the idea of stabilizing the fundamentally unstable transthyretin that occurs in people with a risk for amyloidosis, is the idea of either transcriptional suppression, silencing of the production of transthyretin. We've heard a lot about that with patisiran and other agents, but also now the potential for actually gene editing. There was a phase one study presented looking at the use of CRISPR-Cas to edit the transthyretin gene and shut it off. That's exciting. I'll be supporting the program that's coming from this sponsor for their phase three trial. So we'll have more data, in upcoming years. On the other side of the equation, however, in addition to stabilizing and shutting off production of transthyretin, is the idea of actually removing the
Mm.
transthyretin from the tissues, right? And this is really fascinating because depending on the patient type, younger patients typically have more production and less issue with removal, whereas older patients, they have an inability to clear the transthyretin. So the idea is that in addition to reducing deposition, you might be able to remove it using any number of different therapies under development, including a monoclonal antibody. There was a New England Journal of Medicine report that this monoclonal not only reduced the amount of cardiac MRI deposition, it improved the nuclear medicine scans, and very importantly, also showed evidence for reduced tissue injury with less troponin and NT-proBNP release. So the amyloid space has become a completely hot area for clinical trials and with a lot of promise for treating a very, very unfortunate disease.
Yeah, we move from stabilization now to regression of disease, which is
Yeah.
very exciting. What about acute heart failure? What strides did we make there?
Yeah. Once again, an area that, a few years ago was sort of where clinical trials went to die. Now we're seeing that we're learning the lessons from past studies about how to better approach acute heart failure studies. And what I mean by this is acute treatment is important, but if there's no long-term therapeutic attached to the acute treatment, it probably won't affect long-term prognosis. And what we saw in 2023 are more data about the importance of SGLT2 inhibitors. The DAPA Resist study showed an incremental effect of dapagliflozin on top of loop diuretic use to decongest patients more efficiently. We saw this in MPulse as well in 2022. These are studies looking at empagliflozin and dapagliflozin in hospitalized patients, but critically important to get the long-term benefits after the acute decongestion is continuing the drug after discharge. Same message learned from the Paraglide study. This was an acute HFpEF study looking at the treatment of patients with sacubitril valsartan. Now, we know that in outpatient ambulatory heart failure, sacubitril valsartan is effective in reduced EF, as well as among people with HFpEF in quotes, but with an ejection fraction at or below around 60%. In Paraglide, the investigators looked at the use of sacubitril valsartan in hospitalized HFpEF and showed, once again, in people with an ejection fraction less than 60, there was greater reduction in NT-proBNP and a longer term improvement in kidney function as well as reductions in clinical events. Once again, the message, however, is treat early in the hospital, but continue it in the outpatient setting. And it sends a very important message for clinicians that the clinical trials of acute heart failure should not be viewed separate from chronic heart failure treatment. They're on a continuum, and these therapies started in the hospital can and should be continued after discharge.
Yeah, I mean, you can have all the great basic science in the world, but unless you have the implementation science to continue the drug and adherence, it just doesn't matter, Jim. Uh, Talk to us a little bit about, kind of harping on that a little more, strong heart failure and, what we learned there.
Yeah, absolutely. And for the viewers, we have a um, intent focus on implementation science at the Baim Institute for Clinical Research. Dr. Harriet Van Spal directs our implementation programs, and we have some programs that we're currently putting together on this very topic on optimal implementation of heart failure therapies. And one thing that's been learned from the Strong HF study is that it's not only safe but very effective to initiate and rapidly titrate beta blockers, sacubitril valsartan, SGLT2 inhibitors, and spironolactone or similar in patients with heart failure. The problem is that there are just these tremendous gaps. So even though Strong HF was incorporated in the ESC guidelines now, they recommend rapid titration up to, getting to target by 4 weeks after hospital discharge. In most cases, domestically here in the United States, nowhere near that occurs. And so we have a guideline directed medical therapy clinic at the Mass General Hospital that I
Mm,
coordinate. We're generating tons of really exciting data from this two site study. We have two different sites that perform it. And we're now proposing a multi center randomized trial to really show proof that GDMT titration can happen rapidly and safely and be expected to reduce events, much like was shown in Strong HF.
yeah. And now let's look at weight loss. I mean, amazing data from, the Select Heart Failure study. Talk to us a little bit about that.
Yeah, no year-end summary of clinical trials for any topic, whether we talk about heart failure, coronary disease, diabetes, kidney disease. Every year-end summary is going to include something about GLP-1 receptor agonists, and it's sort of interesting. Sort of the two titans in diabetes care now are the GLP-1 receptor agonists and SGLT2 inhibitors. I mentioned the SGLT2s already. GLP-1s. I mean, what can you say about the data that are generated this year? You mentioned Select, which was a study actually of more than 20,000 individuals without diabetes but with obesity and cardiovascular disease. Most had a prior MI, but there were around 20% that had heart failure. Treated with semaglutide to, as a primary goal to help them lose weight, and they lost, between 10 and 15% body weight. But what was really remarkable about Select was that across each of the outcome measures, even if you can quibble a little bit about the statistical significance or how it was approached, um, not only was weight loss achieved, but there was reductions in pretty much every hard cardiovascular event, including mortality. So what this says is that these drugs are above and beyond just weight loss. They have an atherothrombotic impact. They very likely affect blood pressure. There's a good suggestion they may affect volume status. In heart failure, the STEP HFpEF trial looked at the impact of semaglutide among individuals with heart failure with preserved EF who also had obesity, body mass index greater than 30. I should mention in SELECT, they actually enrolled people down to a BMI of 27. and
Yeah,
that's half of the U.S. population when you
right.
think about the prevalence of overweight in our population. In step HFpEF, it was people with 30 or greater, and in these people with heart failure, once again, there was an average 10 to 15, even more percent weight loss, up to 30 pounds was lost in most of the people treated in the semaglutide arm. And remarkably, not only did patients feel better, not surprisingly, but they improved their 6-minute walk distance and they had a significant, very significant reduction in N terminal pro BNP, really implying a mechanistic benefit of weight loss on heart failure. So
It's
why
just not that you lost weight and you felt lighter and you could walk more and you felt better. It really physiologically made a difference.
exactly, and when you think about why that might be, I mean, NT-proBNP doesn't lie, right? I mean, the fact that somebody loses 30 pounds, of course they're going to feel better and they may be more active as a consequence. But the reduction in natriuretic peptides says that there's something intrinsic to the myocardium that is improving after this weight loss, whether it's reductions in epicardial fat or myocardial steatosis with improvements in energetics. It may be less restraint in the pericardium from loss of epicardial fat. Regardless of the mechanism, which we really do need to understand better, this is a first tentative step into where I think the space needs to go with respect to weight loss therapies and heart failure.
And Viviane Takati might argue that it's an improvement of microvascular function. She has some data from people who underwent banding, and with weight loss, their microvascular function and weight loss, their microvascular function improved. Well, an exciting year, Jim. Any big predictions for 2024?
I suspect that we're going to see more of the same moving into 24 with respect to the GLP-1 receptor agonists and everything after that. So, one of my favorite albums by the Counting Crows, August and Everything After. This is semaglutide and everything after, right? So it's the field now is full of new weight loss drugs that prove to potentially be even more potent and may have more favorable safety profiles, particularly for longer term administration. So I suspect we're going to see more studies in not just heart failure, but across the broad range of cardiovascular disease. We're anxiously awaiting the results of the FLOW study, a trial that was suspended early of semaglutide in people with chronic kidney disease. But in the heart failure space, I predict that if we're really going to move the needle and get people using GLP-1 receptor agonists as a treatment for heart failure, we're going to need to see outcomes trials in that space. I really think that we're drawing to a close with respect to the era of SGLT2 inhibitor trials as these drugs are going generic. Same thing with sacubitril valsartan, but implementation trials of those therapies are now on the near horizon, and we're proposing one. We're hoping to do one through the BAME Institute to show that we've got these great tools, but we have to use them in order to improve outcomes.
Jim, thanks for taking time out. Thanks for joining us today. And thanks to all of you in the audience for joining us for this year in review. Thanks, Jim.
Thanks, Mike.